Welcome back, deep divers. Today, we're plunging into a topic that is often overlooked, frequently misdiagnosed, actually, but it's profoundly impactful. We're talking about these tiny nerve fibers in your body, the ones that might be sending some pretty big, urgent messages. Okay, let's unpack this a bit. Imagine feeling, unexplained burning pain, maybe strange tingling, or even problems with sweating, but then all your standard nerve tests, they come back completely normal.
Super frustrating. Right. Well, our deep dive today is into something called small fiber neuropathy, or SFN for short. So our mission for you, our listener, is to really pull out the key nuggets of knowledge from the research we've looked at, give you a shortcut to understanding this critical condition, what it is, why it happens, and importantly, why catching it early can be such a game changer. Think of it like tuning into a hidden language your body uses to communicate.
Indeed. And what's really fascinating here, I think, is that SFN isn't just another medical condition. It often plays out like a real-life detective story. It can act as this crucial early warning system, hinting at other, maybe bigger systemic diseases you might not even know you have yet. So understanding SFN, it really means recognizing those subtle signals before they become, well, overwhelming.
Okay, let's start with the basics then. When we talk about these small fibers, what exactly are we talking about? Our sources explain there are two main types involved in SFN. First, you've got the A fibers. Now, these are thinly insulated, sort of like a fast express lane for sensations, and they primarily transmit that sharp pain and cold feeling.
Right. And then you have the C fibers. These ones are uninsulated, more like a scenic route maybe. They handle that duller burning type of pain and warmth. But crucially, they also regulate essential autonomic functions, things like sweating, digestion, even your heart rate.
And that's a really big differentiator, isn't it? Because unlike damage to the larger nerve fibers, the ones that might affect muscle strength or your sense of vibration, SFN primarily causes these very specific sensory and autonomic symptoms. So if your reflexes check out okay, but you've got these other persistent issues, well, it points us towards these smaller, but just as vital pathways.
Absolutely. And what's truly important here is just how significant recognizing SFN early can be. If we connect this with the bigger picture, these tiny fibers are often, the first to wave a red flag. They signal that something larger might be going wrong somewhere in the body. Catching SFN can mean catching serious underlying issues like diabetes or autoimmune conditions much, much earlier. And beyond just being a warning, it also has a huge impact on daily life because of the chronic pain. So identifying it early is really key to improving quality of life.
Yeah, let's make this more concrete. Our sources give a good example. Imagine a 45-year-old woman. She's been having this persistent burning pain in her feet for about 6 months, and it gets worse at night. She also notices she's sweating excessively, but strangely, only in her upper body. But here's the thing. She reports no weakness, and doctors confirm her sense of touch is perfectly normal.
Okay, so what do these specific features tell us? That burning pain she describes, that's a classic symptom linked directly to those C fibers we just mentioned. The excessive sweating, what doctors call hyperhidrosis, that points straight to a problem in the autonomic nervous system. Again, another C fiber job. And crucially, the fact that her touch sensation is preserved and she has no motor symptoms. That strongly suggests it's the small fibers involved and helps us rule out large fiber damage. That specific combination of symptoms really guides the diagnostic path towards SFN.
Okay, so these small fibers are clearly important. But why are they the ones that seem so vulnerable to damage? What makes them susceptible?
Our sources give some really good insights here. For one, they lack that thick protective myelin sheath you find around the larger nerves. You can think of it like maybe a high-performance sports car built for specific tasks, but maybe inherently a bit more fragile than, say, a rugged SUV.
Right. And they also have a very high metabolic demand. That means they need a constant, really precise supply of energy to function properly. This makes them incredibly sensitive to any kind of metabolic stress in the body, like high blood sugar, for instance. And finally, they have these exceptionally long axons, which is the main sort of wire of the nerve cell. That just means there's more length, more surface area for damage to potentially occur along the way. And generally, this damage can come from, well, metabolic issues, toxins, immune system attacks, or even sometimes genetic factors.
Okay, so how does that vulnerability play out in real conditions? You mentioned diabetes. It's exactly.
Diabetic SFN is a prime example we see in the research. You have patients with poorly controlled diabetes, right? Consistently high blood sugar levels, maybe an HbA1c of 9.5%, like in one case study. This chronic high sugar leads to increased oxidative stress and problems with the mitochondria, the energy factories, specifically in those vulnerable C fibers. And the end result, axonal degeneration. The nerve fibers literally start to break down. And that causes that characteristic burning pain and the autonomic symptoms we talked about. This mechanism really underscores why tight control of blood sugar is just absolutely essential to prevent diabetic SFN from getting worse.
Right. So what does this mean for the common causes of SFM then? Where does diabetes fit in the bigger picture? Our sources tend to categorize the usual suspects into a few key groups. The biggest one, accounting for maybe 30 to 50% of cases, is metabolic factors. Diabetes is definitely the most common here, but prediabetes and metabolic syndrome are also significant players. Yeah, absolutely. Then you have autoimmune conditions. This is where the body's immune system mistakenly attacks its own tissues. Think conditions like Sjogren's syndrome or lupus. Infectious causes can also trigger it, things like HIV, hepatitis C, or Lyme disease. And certain toxic exposures are known culprits, too, like some chemotherapy drugs, excessive alcohol use, or even, surprisingly, taking too much vitamin D6.
And it's also worth mentioning, right, that for a chunk of cases, maybe 20, 30%, especially in older patients, doctors actually can't find a clear cause. That's what they call idiopathic SFN.
That's right. And what's truly intriguing now, and this is a major emerging insight from recent research, are the connections to current global health issues. Take post-COVID-19 SFN, for example. There's growing evidence suggesting that a COVID infection can actually trigger SFN. It's likely happening through immune-mediated mechanisms, and it seems to be contributing to many of those long COVID symptoms, like new-onset burning pain or problems regulating body temperature. It just shows how widely external factors can impact these delicate nerves.
Wow. And there's another connection that sounds really significant, the one with fibromyalgia.
Oh, yes. This is potentially huge. Our sources highlight that some cases previously diagnosed simply as fibromyalgia, that condition with widespread chronic pain, might actually be undiagnosed SFN. Studies are finding reduced small nerve fiber density in skin biopsies from certain fibromyalgia patients. This isn't just like a minor link. It could be a real paradigm shift in how we think about chronic widespread pain. It suggests that for quite a few people, what was thought to be one condition might actually be a treatable nerve issue at its core.
Okay, so given this huge range of potential causes and these sometimes confusing symptoms, how does a doctor actually start to zero in on SFN? What are the telltale signs? When we talk about the sensory symptoms, what should people look out for? We're talking burning, stinging, maybe electric shock sensations, often worse when resting or at night. You might also get allodynia, that's pain from something that really shouldn't hurt, like clothes brushing against the skin, or just increased sensitivity, hyperesthesia to pain and temperature. And these typically start in the feet and hands, right? Often in that classic stocking glove pattern.
Exactly. But it's definitely not just about pain. You also have those crucial autonomic symptoms to consider, which really point towards the C fibers being affected. This could show up as anhidrosis, which means reduced sweating, or kind of paradoxically, hyperhidrosis, which is excessive sweating. Other signs might include dizziness or feeling lightheaded when you stand up, that's orthostatic hypotension, or digestive problems like bloating or constipation, even dry eyes, dry mouth, and sometimes sexual dysfunction can be part of the picture.
And why do these specific symptoms happen? What's the mechanism?
Well, it goes back to those fibers. The A and C fibers are the very pathways that carry signals for pain and temperature, and they control all those vital autonomic functions.
Yeah.
So when they get damaged or dysfunctional, you either get what we call positive symptoms, like the burning pain, which comes from the nerves being hyperexcitable, or you get negative symptoms, things like numbness to temperature or reduced sweating, which happen when there's actual loss of the nerve fibers themselves.
Okay, so let's say these symptoms make you or your doctor suspect SFN. How do they actually confirm it? What are the steps?
It always starts with a really thorough clinical evaluation, right? A detailed history, when did symptoms start, how they changed, any other health issues. Then comes a neurological exam, but one that specifically tests pinprick and temperature sensation. And the key diagnostic clue here, as we mentioned, is that other nerve functions like vibration sense and muscle strength are typically normal in SFN. That helps distinguish it from large fiber problem. Precisely. Now, for the diagnostic tool that's often considered a gold standard, the skin biopsy, the research describes it as a pretty straightforward procedure, usually a small 3-millimeter punch biopsy taken from the lower leg, near the ankle typically. This tiny skin sample is then specially stained using something called PGP 9.5 immunohistochemistry, which basically lights up the small nerve fibers so they can be seen under a microscope. What doctors then do is count the intraepidermal nerve fiber density, IENFD. How many fibers are there in that top layer of skin? They compare that count to establish normal ranges for the patient's age and gender. If the density is reduced, say below the 5th percentile, it confirms the diagnosis of small fiber loss. Its big advantage is that it directly visualizes the problem, making it highly specific. The downside is, well, it is a minor invasive procedure and maybe not available everywhere.
Right. And you mentioned standard nerve conduction studies. NCS are usually normal. That seems like a really important point.
It's a critical diagnostic pearl, absolutely.
Mm-hmm.
NCS primarily tests the large myelinated fibers, so a normal NCS result doesn't rule out SFN. There are other tests that can sometimes provide supportive evidence, though, things like quantitative sensory testing, or QST, which measures perception of heat, cold, and pain more finely. And autonomic function testing can directly measure things like sweating response or heart rate variability to pinpoint autonomic dysfunction.
But hang on, there's something newer too, isn't there? Something non-invasive that gives a kind of window into these tiny nerves.
Ah, yes, you're talking about corneal confocal microscopy, or CCM. It's a really fascinating technique. It's completely non-invasive and uses a special microscope to actually visualize the small nerve fibers directly in the cornea, the clear front part of your eye. It measures the density of these corneal nerve fibers, and studies show that this measurement correlates quite well with the IENFD results from a skin biopsy. What makes it particularly exciting is that you can do it repeatedly without any harm. So it's potentially fantastic for tracking early nerve damage, especially in conditions like diabetic SFN, and for monitoring how well treatments are actually working over time, all without needing another biopsy.
Okay, so you get the diagnosis confirmed, maybe via skin biopsy or supported by CCM and other tests, but that's not the end of the story, is it?
It's not at all. Confirming SFN is really only half the battle. A comprehensive lab workup is absolutely essential to try and identify those underlying causes we talked about earlier. This is the detective work part. Our sources consistently recommend a thorough screening process. This usually includes checking for metabolic issues, things like HbA1c for diabetes, fasting glucose, lipids, thyroid function, then looking for autoimmune markers, ANA, anti-SSB for Sjogren's, rheumatoid factor, complement levels, things like that. Screening for relevant infectious diseases like HIV, hepatitis C, or Lyme disease if exposure is possible. And in certain situations, particularly if there's a family history or specific features, genetic testing might be warranted. Looking for mutations in genes like SCN9A or SCN10A, which affect sodium channels, or the GLA gene for Fabry disease. It's so important to reinforce this. We only label SFN as idiopathic, meaning no known cause, after meticulously ruling out all these potential underlying conditions.
And this really brings us to a vital point, getting the diagnosis right. You mentioned misdiagnosis is common. Why is that, and why does it matter so much? SFN can mimic other things, right?
Exactly. It needs to be carefully differentiated from, say, large fiber neuropathy, which, again, would usually show abnormalities on nerve conduction studies. Or fibromyalgia, which causes widespread pain but typically doesn't have that objective nerve fiber loss seen on biopsy, though the lines are blurring there as we discussed. Other conditions like erythromelalgia or complex regional pain syndrome, CRPS, might also be on the differential list. And why does differentiation matter so much? Because a misdiagnosis leads to delayed or incorrect treatment. For example, treating someone with fibromyalgia might involve certain antidepressants or exercise programs, whereas treating SFN really requires getting at the underlying cause, like optimizing blood sugar for diabetic SFN or using immunosuppressants for autoimmune SFN. The approaches can be very different.
Okay, that makes perfect sense. So once SFN is diagnosed, and ideally you found an underlying cause, what's the game plan for treatment? Our sources seem very clear on the main principle.
Yes, the core principle is absolutely treat the underlying cause. That's the key to preventing further progression and potentially allowing for some nerve regeneration. So if the cause is metabolic, like diabetes or prediabetes, the focus is squarely on optimizing blood sugar control, aiming for an HbA1c below 7% generally, along with weight management and regular exercise. If it's an autoimmune cause, treatment might involve immunosuppressive medications like prednisone or maybe IVIG or disease-modifying drugs depending on the specific condition. Sometimes stronger agents like rituximab are needed for refractory cases.
And what about toxic causes?
If a toxic agent is identified, say, excessive alcohol or a particular medication like chemotherapy, the primary step is to discontinue or modify it. Stop drinking alcohol, perhaps adjust the chemo dose if possible. And for the less common genetic causes, specific targeted treatments are sometimes available or being developed, like enzyme replacement therapy for Fabry disease or potentially sodium channel blockers for certain channelopathies.
Okay, so treating the cause is number one. But what about the symptoms? The pain, the autonomic issues, they can be debilitating. How are those managed?
That's equally critical for improving a patient's quality of life, absolutely. For pain management, doctors often start with medications specifically designed for nerve pain. First-line options usually include drugs like tipropentin or pregabalin. If those aren't effective enough or cause side effects, second-line options might include certain antidepressants that also work on nerve pain pathways, like duloxetine or amitriptyline. Topical treatments can also be helpful for localized pain, things like lidocaine patches or capsaicin cream. And one crucial piece of advice from the sources. Opioids are generally best avoided due to the high risk of dependence and other issues. They're usually reserved only for very severe refractory cases under close supervision.
Makes sense. And the autonomic symptoms, the dizziness, sweating problems, digestive issues.
Yeah, those need targeted management too. For autonomic symptoms, it depends on the specific problem. For that orthostatic hypotension, the dizziness on standing, there are medications like midodrine or fludrocortisone, plus lifestyle advice like increasing salt and fluid intake. For GI dysmotility, the bloating, constipation doctors might prescribe prokinetics to help move things along or recommend specific dietary changes. And for things like dry eyes or dry mouth, simple measures like artificial tears or saliva substitutes can often provide significant relief. It really requires a comprehensive, symptom-by-symptom approach to make daily life more manageable.
Okay, now here's where things get really exciting looking towards the future of SFN treatment. Researchers aren't just focused on managing symptoms anymore, right? They're actively developing therapies that target the underlying problems, the actual nerve damage.
Exactly. This is where the hope really lies for disease modification. Our sources highlight several promising avenues in emerging therapies. One example is an investigational peptide called ARA290, or sebenontide. It's being studied specifically for sarcoidosis-related SFN. The idea is that it activates one of the body's own innate repair receptors to try and promote nerve regeneration. Early phase 2 trial results showed some promise for reducing pain, which is encouraging.
And what about the genetic forms?
There's work being done there too, particularly in gene therapies. These are highly targeted treatments designed for hereditary SFN caused by specific genetic mutations, like those affecting the SCN9A sodium channel gene. They might use techniques like antisense oligonucleotides to try and modulate how that faulty gene is expressed. It's still very early days, mostly preclinical development, but it's a potential path forward for those specific types. And finally, there's ongoing research into using nerve growth factors like recombinant human nerve growth factor, rhNGF, to try and stimulate small fiber regeneration. Results in clinical trials have been a bit mixed so far, but the concept is sound. These emerging therapies are really aiming for that disease-modifying effect, offering hope that goes beyond just controlling the symptoms day to day.
That's really encouraging. So connecting this all back to the bigger picture, what does the outlook, the prognosis, generally look like for someone with SFN?
Well, it's highly individualized, as you might expect. The prognosis really depends on several factors. What's the underlying cause? How early was it caught and treated? What's the patient's age? And do they have other health conditions, comorbidities? If an underlying cause can be identified and effectively treated early on, the progression can often be slowed or even halted, and some degree of nerve regeneration might be possible, leading to symptom improvement. But without proper management, or if the cause is unknown or untreatable, there can be significant complications down the line. We're talking chronic, disabling pain, depression, a seriously reduced quality of life, risks of falls from orthostatic hypotension, and in diabetic SFN, things like foot ulcers developing because the patient can't feel injuries due to the sensory loss. So early recognition and appropriate tailored management really do make a huge difference in improving patient outcomes. It just underscores the power of understanding these, well, seemingly minute details of our nervous system.
Okay, deep divers, let's try and wrap this up. Let's bring it all together. What are the absolute key takeaways from our deep dive into small fiber neuropathy today? First, I think, remember that normal standard nerve conduction studies, NCS, do not rule out SFN. That seems like a massive point. Second, that skin biopsy, while a bit invasive, is still considered the gold standard for confirming the diagnosis by visualizing the nerve loss. And third, always screen for those underlying causes. Don't just stop at the symptoms, even if they seem typical. Dig deeper.
Absolutely. And on the treatment side, the core principle: treat the root cause whenever possible to prevent progression. Take a multimodal approach to managing the pain using different types of medications, maybe topicals, and make sure to address both the sensory and the autonomic symptoms because both significantly impact quality of life.
Right. And looking ahead, keep an eye on those research frontiers. Things like post-COVID SFN as a newly recognized cause, that non-invasive corneal confocal microscopy for diagnosis and monitoring, and those targeted therapies, especially for genetic forms that are being developed.
Yeah, what's really fascinating and maybe a bit concerning is that SFN is still often underdiagnosed. It gets mistaken for other chronic pain syndromes quite frequently. But as we've really hammered home today, it can be that first crucial clue pointing towards more widespread systemic diseases. Catching it early, managing it appropriately, it doesn't just improve symptoms day to day, it can genuinely change a patient's entire health trajectory. It really highlights the power of listening carefully to those subtle signals from our nervous system.
So what does this all mean for you, listening? Well, maybe the next time you or someone you know mentions that unexplained burning pain or strange tingling or unusual sweating, remember it might be more than just a passing discomfort. It could be the body sending a really vital message through its smallest fibers, urging you or them to look a bit deeper. It makes you wonder, what other small symptoms might we be overlooking in our own health that could actually be sending important signals? Keep exploring, keep questioning, and definitely keep taking those deep dives with us. Until next time, stay curious.